Greetings of the day, folks. Today we are going to discuss about neurological disorders or complications in HIV patients. So, neurological disease in HIV patients may be related to opportunistic infections, neoplasms, impact of HIV infection on CNS, or HIV treatment itself. So, there are multiple causes. So, it might be infection, neoplasms, or the HIV treatment. So when the patient presents to the ED, he presents with seizures or altered mental status, headache, or meningismus, and focal neurological deficits. So the patient with HIV presenting to the ED with headache, seizures, and altered mental status or focal neurological deficits, with or without fever, should have neuroimaging, especially in patients with CD4 count less than 200 cells per millimeter cube. Although NCCT is typically the first imaging modality used in ED, CECT and MRI may be needed if CT findings are equivocal or negative. If no mass lesion exists, lumbar puncture follows to assess or obtain the following, like CSF pressures or WBC counts, differentials, protein, glucose concentration, gram staining, India ink staining, and bacterial culture, mycobacterial fungal culture, toxoplasmosis, cryptococcosis, antigenesis, coccidioidomycosis, titers, and polymerase chain reaction assays, or for JC virus, and like Epstein-Barr virus, cytomegalovirus, toxoplasma gondii, and herpes simplex, HSV 1, 2, and 2, and varicella zoster. So this is an exhausting list of that. So we have to save additional CSF for any further testing. So toxoplasmosis, serology, and quantiferon tuberculosis testing too can be sent. Okay, based on this, we might be pinning down to some certain diagnosis. Okay, so this is the ED presentation and some of things that we may have. Now let us dive into the specifics of the HIV associated like diseases like HIV associated. First one is HIV associated neurocognitive disorder. So the HIV associated neurocognitive disorder is also referred to as HIV encephalopathy or HIV associated dementia or AIDS dementia complex. So it is a subacute disease that is progressive, and you might find it very subtle. Like there are nuances which you might be finding in these patients. Like there will be some recent memory cognitive deficits, like the person might not remember his childhood memories, or there might be some behavioral disturbances in these patients. And in up to 50% of the patients on ART may have some sort of like HIV associated neurocognitive disorders. Okay, so many patients might be exhibiting only mild deficits, but many or inadequately treated patients might be having an advanced form of the HIV associated, okay, neurocognitive dementia, or it may be there will be moderate to severe cognitive impairment with behavioral changes also. So HIV associated dementia is a diagnosis of exclusion rather than there are no certain there are no particular like criteria for this, but it is always an end of the list that it is bottom of the list. Okay, so once MRI, LP, and lumbar puncture have been ruled out, other pathologies then last, and new signs or symptoms in a patient with known HIV associated dementia should prompt workup for other CNS processes. So ART is the most effective treatment for HIV associated dementia. Okay, so you need to ramp up on your ART treatment and make sure that the patient is compliant to the treatment. Okay. So now coming to the second one is the toxoplasmic encephalitis, which is also seen since like after the introduction of ART, toxoplasmosis encephalitis remains most commonly reported neurologic like opportunistic infection. It occurs most commonly in patients who have a CD4 count of less than 100. Like as you can see that if the patient has acquired the infection, has earlyhood, like at the adulthood or anything, the latent bradyzoids will be reactivating when the CD4 counts drops below 100. Okay, so the symptoms might include same like headache, fever, focal neurological deficits. The patient might be having altered mental status or seizures and some behavioral changes. So on unenhanced CT scan, toxoplasmosis will look like a multiple subcortical lesions with predilection for basal ganglia and also corticomedullary junctions. The CECT, the contrast enhanced, will show multiple ring enhancing with surrounding areas of edema. Okay, so the MRI is more sensitive in detecting the toxoplasmosis than the CECT. So consider primary CNS lymphoma as another potential cause or mimic. Okay, so CSF may not be available since many patients are 100% like it's like may are at risk for herniation, so may not be available. Okay, so and PCR, although highly specific, is not sufficiently sensitive to detect toxoplasma gondii. So you may need to be careful, and also like most of the patients with them have a positive serology IgG in combination with symptoms. Okay, so the treatment should be started. So the patient should be started on IV pyrimethamine plus sulfadiazine plus leucovorin for antagonizing the folic acid antagonist effects and supplementing them. And also clindamycin may be substituted if the patient is allergic to sulfadiazines, because many of the patients might be having allergy to sulfur drugs. Okay, so some trials have shown that trimethoprim sulfamethoxazole may also have an equal efficacy. And also, if the patient is having a mass effect, the corticosteroids can aid in treating them. Okay, so for patients responsive to toxoplasmosis, use chronic therapy with oral sulfamethoxazole and trimethoprim. Okay, so for as a prophylaxis. And then coming to the and when the patient is tested like CD4 counts of less than 100, then patient might be getting the prophylaxis with the trimethoprim and sulfamethoxazole. Okay, so now the next one is the cryptococcal meningitis, and it is seen when the counts of CD4 counts drops less than 50 cells per millimeter cube. And again, here the most common presentation will be, as this is an infection, the patient might be having fever, headache, ultimate state is focal neuralgia. Sometimes you can find seizures. And this presentation is subacute, and meningismus is uncommon. This is one thing you must be uh, make sure that you remember. And although communicating hydrocephalus with high intracranial pressure may develop, CT imaging may be normal or non-specific. Okay, so diagnosis of the cryptococcal infection in the CNS in HIV patient relies on like antigen testing, like it is 92% and 83% specific, and also fungal culture because cryptococcus is a fungus. And also staining with India ink. Okay, India ink and serum cryptococcal antigen testing helps, but has a lower sensitivity than CSF testing. Okay, the expected CSF WBC count elevation is often absent in the patient with AIDS because this is a immunological disaster disease. So, although increased opening pressure is common, drainage aiming to reduce pressure by 50% or to less than 20% is best. Okay, the patient with CNS cryptococcosis requires admission and also requires amphotericin B and oral flucytosine for 14 days. Okay, followed by fluconazole for 8 weeks to clear the CSF, and long-term maintenance will follow that. Following that. Okay, then comes the other miscellaneous neurological disorders like in the cytomegalovirus, which may also cause this encephalitis in the brain or radiculomyelitis in the spine, or it may cause in the mononeuritis multiplex in the peripheral nervous system. And non-specific periventricular enhancement may be seen in CMV infection, and it is highly sensitive, and specific CSMP-CR may be seen. Okay, so this patient should be evaluated for encephalitis, and also concurrent retinitis should be seen. And for this, ganciclovir, just like then shoots the cytomegalovirus and the okay. So ganciclovir is the stay of treatment, and sometimes there might be having a reactivation of JC virus, which may lead to progressive multifocal leukoencephalopathy with neurofocal neurological deficits developing over weeks. Okay, although it is acute, it may mimic stroke, and initiation of ART is key to management in these patients. And multifocal demyelinating lesions exist on imaging. Sensitivity of CSF PCR for GC is variable, and incidence of primary CNS lymphoma has declined since introduction of ART. Once diagnosed, the prognosis is poor. Okay, so the median survival is around 2 months. And sometimes you might find CNS lymphoma which have a non-specific symptoms or focal neurological deficit without fever. So post-contrast imaging may demonstrate enhanced lesion, and presence of EBV is highly sensitive. Okay, so this is one thing you must remember. And also sometimes you may find other or bacterial meningitis, herpes, HSV infection, neurosyphilis, TB, and also patient might be prone to CVA and also metabolic encephalopathy. Neuropsychiatric disturbances may occur from HIV therapies like including ART, such as IV runs or drug therapies. Okay, so the peripheral neuropathies are common either because of like chronic infection or HIV-associated distal sensory polyneuropathy or treatment-related toxicity. Okay, so change in the treatment regimen may address the later, reserve the opioids for short duration and pain, and for severe pain, and topical capsaicin or lamotrigine may aid in the treating these conditions, and also autonomic neuropathies and inflammatory demyelinating polyneuropathies may also occur in scene. So this concludes this video. Thank you very much.